worked under a private company and is now currently a senior executive officer. There's no history of cigarette, vape, alcohol, or illicit drug use. There was no family history of autoimmune disease or family history of mental illness. Pre-morbidly, she was described as an introverted and quiet person and always has had a small circle of friends, preferring to be alone on most days, and tends to keep things in order when it comes to her own rooms and belongings, but not intruding onto others. Just to paint a brief picture, upon admission, she is a young Chinese female. She was wearing hospital attire with messy hair. There was no eye contact present during the interview, and she remained very guarded. Her speech was low tone, volume, and amount, and her mood was sad, but her effect was blunted. Despite that, she was not open to being assessed her suicidal thoughts. And during admission itself, she was a young Chinese female, hospital attire, downcast gaze, coherent and relevant, but the speech was still low tone, volume, and amount. The mood was all right, but the effect was still restricted. Denies perceptual disturbances during this time, but there was presence of suicidal ideation. Skip the next one. General systemic examination. She was alert, her GCS was full, lung and chest was clear, CVS was dual rhythm, no murmur, and abdomen was soft and untender, vital signs were stable. We did a number of investigations for her, baseline blood investigations, which I'll show the results soon, with a psychological assessment, MOCA, which will be presented later by the next speaker. We did a radiological assessment to ensure that there was no organic issues. We had to work that up, and her ECG was sinus rhythm. These were the blood investigation results. Generally, they were all normal, along with the LFT and TFT. And this is the fasting blood sugar and fasting serum lipid. Unfortunately, we couldn't really compress the whole slide. This is just one of it for the non-enhanced CT. But the findings are as follows. There was no significant intracranial abnormalities seen. So with all of that being presented to us, we had a provisional diagnosis of attenuated psychosis syndrome with a close differential diagnosis of major depressive disorder with anxious distress, with psychotic features and high suicidal risk. We had treated her. This is as of her latest follow-up in September with clozapine, sertraline, which we are currently titrating off, vortioxetine, propranolol as a counter for the side effects of clozapine and benzaxol as well, and clonazepam on the occasion that she's unable to sleep. Previously, she was already tried on olanzapine, but it was discontinued as there was no improvement in terms of symptom control. Lithium was also discontinued. She was unable to tolerate the taste, and aripiprazole was discontinued due to the side effects. Now, a timeline about the inpatient. Upon admission on the 20th of June, the patient initially required parenteral sedation. It was due to her being very restless, and there was an insistence on leaving the ward to complete her work. And during the first 2 weeks, there was minimal improvement. Medication adjustments were also challenging due to the side effects that faced, but the panic attack symptoms slowly subsided. After the first 2 weeks, clozapine was started due to limited progress in the symptom control as mentioned, and 1 month into the treatment, her suicidal ideations decreased, leading to the removal of suicidal precautions. Her condition continued to improve as the clozapine dose was increased, and 3 days prior to discharge, there was a marked change in her effect, with increased reactivity and future planning, which ultimately led her to being discharged. Now, this was the MSc upon the latest follow-up. In comparison, she was more well-dressed. There was still the downcast gaze, but she was more calm and she's able to regain her composure. Her speech was still coherent and relevant. The mood was generally still described as low, but there was no perceptual disturbances, no suicidal thoughts. We were more able to assess the ruminations about her not being good in her work and her studies. Generally, it showed that she had good insight. And it pleases me to say that post-discharge, about a week after, she was seen in clinic on the 1st of August. She was adherent to her treatment. Her family was monitoring her progress, and while she showed further improvements, her family did notice that there was still presence of low mood on occasion, especially when discussing work-related matters, and she expressed concern about her ability to remain at the company. Despite that, there was no active suicidal ideations or passive death wishes, and on the 29th of August, Ms. J was able to perform daily activities at home, helping her aunt with the groceries, completing her household chores. Her sleep and appetite had further improved, and although she continued to experience something she described as a brain fog, there was no suicidal ideations or passive death wishes present. She did express and experience anxiety about returning to work, but she still expressed the desire to return to her job. And overall, they demonstrated improvements in symptom control while still being adherent to the medication. And as of her recent follow-up on the 25th of September, the patient initially appeared anxious, but was cooperative in completing the bullseye worksheet, which will be further elaborated by the speaker as well. She completed it with the therapist while being able to identify the core characteristics, such as personal growth, relationships, education, leisure, and along with that, the steps to progress in each of these areas. And there has been continued improvement of her function and mood. But due to the side effects of aripiprazole, the patient wished to discontinue it, but was agreeable to continue with clozapine on the caveat that it will be increased in dose further. And in an attempt to address the brain fog, the patient was also willing to initiate tioxetine as an improvement for her cognitive symptoms while discontinuing her sertraline. And now it brings us here today to the present and hopefully the future, where we'll have further discussion on the topic, and hopefully we can learn more from the case. I would like to invite the next speaker. Thank you.
Assalamualaikum and a very good morning to all of you. I'm Husna Syahirah binti, Occupational Therapy, Unit Terapi Cara Kerja, JPPP. Would like to present on behalf of Occupational Therapy side for this case presentation. So this case was being referred occupational therapy on 11 July 2024, and the patient status as inpatient, and the reason for referral is for in-ward activities. So the model that I use for this case is PEO model that emphasizes for shaped by the interaction between person, environment, and also occupations. So this PEO model is client-based instead of practitioner-based. So for the frame of reference, I use cognitive behavior FOR, psychodynamic FOR, and also rehabilitative FOR. So for occupational profile, based on patient hope and needs is first, to occupy her time with meaningful activity in ward. Second, to divert any negative and intrusive thought. Third, to improve her management on stress and anxiety. So the method of evaluation that I use is subjective assessment, in which semi-structured interview, and this is the list for objective assessment. So based on the MOCA assessment, this case scored 25/30, which my cognitive impairment, especially difficulty in visual, spatial, or executive, and language component only. For the PSQI, this patient indicate poor sleep quality. And for the interest checklist, from the finding, patient had lack of engagement in leisure participation in comparison before and after the diagnosis. For the future, Ms. J would like to perform this activity in which reading, listening to radio, shopping via online, and housework and laundry. So this is the analysis of occupational performance. So for the area of occupation, the OT concern for this case is ADL and IADL patient able to perform independently. For the rest and sleep, Ms. J claimed that she doesn't have problem in sleep if she got taking medication. And for the leisure, Ms. J does have leisure activity. And for the social participation, Ms. J's social circle involved her family and colleague, and she claimed that she lack of peer to share and express her feeling. And this is for emotional regulation skill. So for overall, this patient doing task activity during in-ward. For the mood, stable during therapy session, but sometimes will be in depressed mode. And for the emotion, tends to isolate and lack of spontaneous interaction with others, especially emotional withdrawal. But for the frustration tolerance, able to deal with complex and sympathize independently without becoming frustrated. And for the social interaction communication skill, for overall patient listen towards question appropriately, has the ability to answer, ask and express when we ask, but prefer to perform the task by her own and seldom seek help from others at first session, but then able to show good interaction towards others after regularly in OT session. So this is interpretation based on practice problem, short-term goal and long-term goal. First, poor insight as the only have slight awareness toward her mental illness. Second, poor coping skill toward her negative and intrusive thought. Third, lack of participation in leisure activity as she is lost of interest and feel meaningless to be alive. Fourth, fair in social interaction and communication skill based on FAA and ARCHIS assessment. And last one is poor sleep quality according to PSQI assessment. So this is the intervention implementation that was given during OT session in what? First, realization technique. The activity is deep breathing exercise. From the outcome and feedback, patient do a bit relief after practicing deep breathing exercise, but she thinks not useful to her because seldom practice and frequent panic attack even have practiced it. Second, art and creative activity. Some of the art creative activity was given, but one of the activity is gratitude tree in group therapy. So this is the task analysis was given. From the outcome, patient feel happy and proud of her previous achievement, and she enjoyed the session and able to know the meaning behind this session. And next, psychoeducation on the importance of leisure activity and exploration of new interests. The activity is Jom Cari Minat. So the outcome is patient enjoy and look happy, more eye contact with others, more interaction with others, and able to take turn. So this is the reference picture for task implementation given throughout the OT session in what? For some leisure activity in a group session, for example, like carrom games activity, Uno card games, and some of creativity. So this is the psychoeducation that I was given on sleep hygiene and sleep diet. So from the outcome, patient do practice some of the point taught in sleep hygiene, but still have sleep disturbance, and currently stay at work and will try to practice it when being discharged, nap on and off in the afternoon on right time, unable to sleep. So next, for improved social skill and good interaction with other people, I do group play activity in group therapy session. So patients show enjoyment and interact well with other patients and cooperative well throughout session. So for the future plan, this case can continue leisure exploration to improve well-being and balance between work and leisure. Second, joining peer support group for continuous emotional support. And last but not least, supported employment for continuous job coaching and job retention. And for the outcome, from this side, Ms. J has good rehabilitation prognosis because Ms. J is independent in ADL and IADL, and for the behavior, Ms. J show high severity in activity and also does seem motivated in engaged activity during work. That's all, thank you.
So I would like to invite the final speaker, the highlight of the day, Associate Professor Dr. Tuti Iriani, to the stage to make her presentation. Thank you.
Good morning, everyone. I think the hall is full today, and thank you, Dr. Amir and Puan Husna, for presenting the case and also the activities in terms of rehabilitation. So I'm honored to present the discussion on this intriguing case of attenuated psychosis syndrome, focusing on its nuances and complexity. So my discussion today would be aims to cover 3 key learning objectives: understanding and defining the features of APS, how it differs from full diagnosis and recognizing its early signs. We will explore how clozapine is used in a range of conditions, not just treatment-resistant schizophrenia. And the third thing is an important intervention called the Sanubari or Pohon Sehat program, which is an intervention that is useful not just for mental health patients with mental illness, but all other medical illness. So moving on to the diagnosis. So I guess I'll summarize the patient again. So she's a young Chinese lady, previous functioning well, but the past few years she gradually showed some changes. She became more isolated, and her first presentation was a panic attack at the accident and emergency. And then she was eventually admitted because she had serious suicidal thoughts. And in the ward, the challenges with this patient was that she was very guarded. She answered in 1 or 2 words. It's really hard to develop a therapeutic relationship with the patient despite trying many angles, many ways, and talking about other things. She kept answering 1 or 2 words, and maybe during the 5th day of the admission, she started to answer what we wanted to hear. You know, when we asked about something, yeah, I'm okay. You could see that her answers were scripted. So that was the challenge here. So let's begin by discussing the DSM-5. So there's a lot of you in first years, I guess. Welcome to UKM. This is your first semester. I think this is your first or second week, okay? And of course, there's clinical students as well. So in psychiatry, we diagnose using this manual. It's DSM-5, we call it, Diagnostic and Statistical Manual of Mental Disorders. We don't have blood investigations to diagnose, to confirm a diagnosis of schizophrenia, to confirm a diagnosis of bipolar, but we have this to help us diagnose a certain disorder. So while this DSM provides a valuable framework for diagnosis, we often find ourselves placing patients in boxes. But the reality is far more complex. Each patient's symptoms can evolve, overlap, and fluctuate. This was certainly the case with our patient, Ms. J, who presented with a mix of depression, anxiety, and we're not sure, maybe psychotic symptoms. So the challenge is not just fitting patients into diagnostic criteria, but seeing the whole person beyond the checklist. So here we come to the idea of checklist. We often feel compelled to tick boxes. Does the patient meet this criterion? What about that symptom? But we know that a patient is more than a sum of their symptoms. It's crucial to balance the guidelines with clinical intuition and patient-specific factors. In our case, ticking the checklist didn't seem to capture the full picture of the patient's experience. So here is a photo of our team members during that time when we were treating Miss J. And here, there's Dr. Nurul here. She's not here today. I think she has to give a talk somewhere else. And of course, there's Dr. Gwen and Dr. Amir, who are the main treating medical officers. And we also had Dr. Adnin, Dr. Vicky, and Dr. Enteng contributing valuable ideas. Each of us brought different perspective and expertise, which allowed us to consider the patient's symptoms from multiple angles and make informed decisions together. However, this is how we looked after week 2, I think, during week 2, week 3, because we were getting nowhere. Miss J kept, didn't want to talk to us as much. Again, giving 1 or 2 word answers, and very guarded. So at many points we felt like this, confused, knowing that something wasn't quite right, but unable to immediately pinpoint the issue. This was a case where the usual diagnostic criteria didn't fully explain the patient's presentation. It felt like the symptoms we were observing didn't fit neatly into any one diagnosis. So again, it's a diagnostic puzzle, didn't quite fit together. There's symptoms there, but they didn't fully align with our expectations. So we had to step back and consider the bigger picture, thinking beyond the surface level and looking for patterns in the patient's history and presentation. So this is the diagnostic dilemma. Is this a depressive illness or is it a psychotic illness? On one hand, the patient had a clear stressor related to work, which could explain the depressive symptoms and suicidality, okay? On the other hand, some of her mood and affects seem more consistent with psychosis. So it was challenging to disentangle these aspects and come to a definitive diagnosis. So what we did is we used the diagnostic, psychiatric diagnostic hierarchy. So this involves starting with the broadest possible diagnosis and then narrowing down based on the patient's specific presentation. So we considered first so in psychiatric diagnostic hierarchy is that diagnosis is not equal. So the organic, is highest in the hierarchy, followed by substance. Substance here includes medication, followed by psychotic, followed by affective spectrum, and so on and so forth. And the last is the personality disorders. So because we did the organic workup and there was no abnormalities, there was no substance use, but then coming down here, we were stuck. We couldn't go down further. We thought that it is here. It is a psychotic illness. The whole team felt that it is more of a psychotic illness rather than a depressive illness, mainly from the mental state examination and a bit from the history. So maybe the diagnosis is, we think, is attenuated psychosis syndrome. It is not formally in DSM-5, but it is in the very back section, in the section where needs to be further studied. So what is attenuated psychosis syndrome? It is a subthreshold psychosis risk syndrome characterized by mild or brief psychotic symptom, okay? Symptoms are less intense and shorter in duration. The key symptoms could be delusions, hallucinations, and disorganized thinking in attenuated form. That means it's not full-blown. And it often includes anxiety, depression, and functional impairment. So in this patient, Ms. J, we couldn't elicit hallucinations. Delusions, could it be delusional mood? We're not sure. What is delusional mood? Delusional mood is when the patient believes that something bad will happen. Something bad will really happen, and they couldn't explain further. And they couldn't explain why, but they just know that something bad will happen. Could it be delusional mood? Yeah, we're not sure. So the thing is, for attenuated psychosis, it is identified as an ultra-high risk state for conversion to full psychosis, okay? Conversion rate to psychosis is about 20 to 23% over 2 to 3 years without intervention. And in terms of prognosis, not all individuals with APS progress to psychosis, but many experience ongoing non-psychotic psychiatric symptoms. Okay. So next is what would be the management of APS according to the literature? According to the literature, is about psychoeducation and close monitoring. So in this patient, this patient lives in Penang. I mean, the family lives in Penang. Patient lives alone in the Klang Valley. Okay, so when she was discharged to Penang, and because of the nature of her symptoms, it's not full blown. We were concerned if we transferred her care to Penang, to other psychiatrists in Penang. So we continued the follow-up here. So she travels from Penang with her mother for follow-up. According to the literature, other treatment options are CBT, and medications would be antipsychotics and antidepressants. In other things would be reducing stress, improving social support, addressing comorbid psychiatric conditions. The next thing I would like to talk about clozapine. So in this patient, Ms. J, was that we tried other medications at first. We tried olanzapine, we tried lithium, but somehow after increasing dose, there was not much response. So we were stuck. As you know, as that I showed the picture just now, what should we do? One of the things she felt was she insisted to go back to work. The reason she insisted to go back to work was so that she's able to complete her work so that she can attempt suicide, or she could die by suicide after she completes her work. So it was really, really serious, and we thought that we needed to do something else. So one is to either offer ECT, which the family was reluctant. And when we looked at the literature, there's this option of clozapine. Okay. So for clozapine, what is clozapine? So we know it is an antipsychotic. It's a second-generation antipsychotic. It is used for treatment-resistant schizophrenia. It is known as the last resort. And if you have no other options, then you offer clozapine in patients with schizophrenia. But it has a lot of side effects. Agranulocytosis, pneumonia, myocarditis are the scary ones. And of course, there's sedation, hypersalivation, and constipation. Okay. Just to mention here, because I think there's fourth year students doing psychiatry postings. So what is treatment-resistant schizophrenia? So based on the TRIP criteria, it is when you've tried 2 different antipsychotics, and each antipsychotic is equivalent to 600 milligrams of chlorpromazine, and one criteria by TRIP says that maybe one of the antipsychotic is a long-acting antipsychotic, okay, but it's not a must, but one of the criteria is said to be that. And plasma concentration is assessed. So here in Malaysia, we don't have, we can't assess the plasma concentration of our antipsychotics. However, what we like to propose here today is that clozapine can be used for other things as well, other than treatment-resistant schizophrenia. It can be used for suicide prevention in schizophrenia and schizoaffective disorder. So this anti-suicidal effect is the key reason we considered clozapine for this particular patient. If you look at the literature, these are other off-label uses of clozapine. So Parkinson's disease, and when you have psychosis in Parkinson's disease, patients who have tardive dyskinesia, they are on first-generation antipsychotics for 20 years, 30 years, and then they develop tardive dyskinesia. You can start clozapine as well. Aggression and hostility, okay. Substance use disorder, positive outcomes in patients with schizophrenia with alcohol or substance use disorder. Bipolar disorder, so it's a third line for mania and maintenance therapy for treatment-resistant cases, and even borderline personality disorders. So these are all mentioned in the literature. So sorry for the clozapine, not clozapine, okay. So our experience with clozapine was in non-treatment resistant cases where patients presented with symptoms ranging from suicidality in schizoaffective disorder to bipolar disorder. So in one case, which one was that? This one, okay. In one case, although the patient did not meet the full criteria for TRS, okay, because she responded to risperidone, but she had problems with adherence, okay. She had problem with adherence, but she sort of became lost to follow-up for 5 years. Family came to give medication, gave medication to the patient through food. They crushed the medications and put them in food. And eventually patient had a severe relapse and was admitted. So actually this particular patient, it did not fulfill treatment-resistant schizophrenia. However, after considering the circumstances, we can't do the same thing again. The last time we started injections, we referred to community. However, the patient didn't allow the community to come. The patient didn't want to continue with the injections. So we had to do something different. So that was starting clozapine, and clozapine was not enough, but clozapine and ECT. Despite the patient being very calm in the ward, not hostile, not bothering any other people, but we started clozapine on her to improve anosognosia. So what has happened for this particular patient, She has allowed the community team to visit, and she has been taking her medications and participating in the ECT. So at least we're not repeating the same cycle again and again. Okay. Other situations with these are the situations that we started clozapine. One is schizoaffective disorder with suicidality. And her dose was 50 milligrams BD. I guess this was the first patient that opened up our eyes, the whole team, the use of clozapine in non-TRS patients. So a low dose was sufficient. In another patient who had a relapse, which I think is mixed episodes. She had both depression, she was suicidal, but she had manic symptoms as well. And the Seroquel was up to maximum 800 milligrams a day. So I discussed about this option of clozapine, and she eventually improved after 50 and 150 milligrams per day. Another patient where he has problems with not tolerating a lot of antipsychotics because he gets akathisia. He can't afford to buy the expensive medications. ECT seems to be a problem because he's working, so he can't go very often. And we started clozapine as well, and we tried titrating up his dose. He reportedly said his sleep is improving. So those are some of the cases. So why do we think clozapine works compared to other medications? One is it could be the receptor activities. When we say receptor activities, is the dopamine, and interestingly, it is not strongly binding to the D2 receptors, but it's binding to the D4 receptors. Okay, and I think year 4 students, which dopamine pathway is it? Is the mesocortical dopamine pathway. So, but it's not just the dopamine receptors, it's also the serotonin receptors. And I think we think that this is the reason that the suicidal symptoms improve. So it's 5-HT1A, 2AC, 6 and 7, okay? And also alpha-adrenergic and histamine and muscarinic. There's this also metabolite activity in terms of which contributes to the neuroprotective effects. There's glutamatergic modulation that impacts schizophrenia and mood disorders. Its role in enhancing neuroplasticity and increasing BDNF levels, and its ability to reduce neuroinflammation. So all these mechanisms together explain why clozapine is so effective beyond just treatment-resistant schizophrenia. So finally, I'd like to highlight the Sanubari program, which we considered for Miss J. So initially, Miss J improved, but however, when she came back during follow-up, she sort of deteriorated a bit. She was not suicidal though, but she started to give monosyllabic answers, 1-word or 2-word answers. So we needed to have a different approach. So we felt that this Sanubari or Pohon Sehat would be a good option. So it is known as kesejahteraan, kesembuhan, dan pengurusan diri. In English, it's well-being, recovery, and self-management. So this initiative is designed to improve overall health outcomes by focusing on lifestyle modifications and preventive care. And it's not just to address the clinical symptoms of mental illness. So this program started in Australia. It's called Optimal Health Program. It incorporates several key elements, include a personalized care plan, mental health support, physical health monitoring, and lifestyle changes. And research has been done on this, and it shows to be effective and helpful in long-term health conditions. What is the framework? The framework is about collaborative therapy and supporting self-efficacy. The collaborative approach means that it emphasizes the partnership between healthcare providers and patients. So instead of we instruct patients, you do this, this, and this, there's partnership, okay? So by fostering an environment of open communication and mutual respect, the program empowers patients to take an active role in their treatment. Self-efficacy. Supporting self-efficacy means recognizing that the person's health should not solely depend on external factors, but rather be supported by the services they utilize. This promotes an internal locus of control, encouraging patients to take ownership of their health decisions and outcomes. So that's why we have the educational resources and skill building activities. So this is the Malaysian version of the Optimal Health Program. Is known as Sanubari, initially known as Pohon Sehat, now rebranded to Sanubari. So for more information about this, you can look at the Facebook Sanubari OHP Malaysia. So there it provides the resources and updates of the program. And it's not just for psychiatric illness, it can be for diabetes, losing weight, maybe studying, pass exams, yeah. So, Dr. Umi Azlin leads this initiative, bringing together a team dedicated to enhance the health outcomes in Malaysia. I was involved in the cultural adaptation of this program back in 2018 to make sure that it suits the Malaysian population. So this is the team that, the initial team, and it's now grown bigger and bigger. Okay, so so this is an example, okay, of one of the activities. It starts with session 1. It asks, what does health means to you? Okay, so what does health means to you in terms of your environment, in terms of your mind, and in terms of your physical health? So what Joylyn answered was in terms of environment, it's the home must be clean and comfortable. In terms of the mind, she's to be able to learn, okay, because she wants to do ACCA, so that's very important to her. And in terms of physical health, she says free from illness. And when I ask what is free from illness means, she says it is free from heart attack. For example, free from heart attack. So the next question is apakah perkara-perkara yang saya lakukan yang mungkin memberi kesan positif kepada kesihatan saya? Okay, so her answer was exercise, gardening. Okay, so she does a bit of gardening, but she does the gardening on her own. She doesn't do it together with her mother. Okay, so the next question here is, apakah perkara-perkara yang saya lakukan yang mungkin memberi kesan negatif kepada kesihatan saya? She said nothing. She answered nothing. Okay. So, so this is some of the activities. This is another activity where you ask the patient, how satisfied are you in all these domains? For example, physical domain. Now, 10 is very satisfied. Sorry, 0 is very satisfied. The inner circle is very satisfied. 10 is the least satisfied. So in terms of physical, where would you put yourself? Where would you say yourself dekat mana? And then there's the emotional domain, social domain. So looking at the patient from all perspectives. So we were able to engage her. How we were able to increase the clozapine dose was using the OHP. Talking about her sleep, she said that she didn't have good sleep, and using that to discuss about how we can help her to get better sleep. So in conclusion, I want to highlight the complexities in diagnosing and treating conditions like attenuated psychosis syndrome, considering the role of clozapine in managing these cases. This case emphasizes the need for a comprehensive patient-centered approach that integrates both pharmacological intervention and psychosocial strategies that Puan Husna has also described. Programs like Sanubari demonstrate how we can effectively combine lifestyle modifications and preventive care. So I encourage us all to explore innovative ways to support our patients, advocate for their needs, and collaborate as multidisciplinary teams. Thank you for your attention.
Thank you so much, Prof. Tuti, for such a comprehensive presentation. Maybe I'll just kick off with the first question, which is actually shared with Prof. Wan, and then we can see how many questions we can take before 9. So it's very interesting, this concept of attenuated psychosis syndrome. We were just wondering, would it be similar in concept, or it's slightly different from what we understand of a prodrome to a schizophrenia spectrum disorder?
Yeah, I mean, I was wondering the same thing as well. Some say that prodromal is longer. I've read somewhere that it says, attenuated psychosis is the milder form of psychosis, while prodromal is before psychosis. Yes. And actually, for this patient, it is not clear. It is not clear whether it is attenuated or prodromal. But because of the suicidal is very clear, and she's not able to explain. Although although we know that she has real stressors at work, however, she's not able to explain things. So it could be prodromal, it could be attenuated psychosis.
Thank you so much, Prof. Tuti. Would the floor have any burning questions? Please come to the mic and ask your question. Yes, please.
Hello, hi, good morning, Assalamualaikum. A very good case, Prof. Chan and also Prof. Tuti. So I'm not sure whether the medical students are still here. Ada tak? Please raise your hand. So I think Prof. Tuti has shown a very good slide on the pyramid of differential diagnosis for patients who present psychosis. So maybe I can ask the medical student, as a UKM student, you must be able to come up with at least 5 differential diagnoses, kan? So can you give me 5 differential diagnoses for patients who present psychosis? Siapa dapat bagi 5, I belanja. Yang depan tak boleh jawab lah. Medical students. Tak ada. Boleh jawab? Boleh datang depan? You can introduce yourself. From which posting?
Hello, Assalamualaikum and good morning. I'm Amir, currently year 4 in psychiatry posting. So, the differential diagnosis for patients with psychosis would be schizophrenia, schizoaffective, brief psychotic disorder. Other than that, if the duration is lesser, just now is schizophrenia, schizoaffective, schizophreniform, and others like if the patient has MDD, can be MDD with psychosis.
Thank you, Amir. But if you look at the pyramid, there is more than that, right? So I think as the medical students and even for any frontliners, because you guys are going to be frontliners, right? So the patient won't come with a label that I am a psychiatric patient. The patient can be a medical patient. So anybody would like to try 5 medical cause or organic cause, the top on the pyramid. Good, Amir. Good try. Siapa?
Such an important question, Prof. Sharul. Please, medical students, take this opportunity, grab it, seize it, and discuss it when all of us are here to give input. It's
Okay,
really
I bagi discount,
important.
3 causes.
It can be due to meningitis, encephalitis, or temporal lobe epilepsy.
Bagi lagi satu yang dekat dengan Prof. Sharul punya subspecialty sikit.
Hamiza Psychiatric.
Okay. So, you pandang I, you rasa apa patient tu ada?
Huh?
You tahu kan what is, my specialty, tahu tak?
Rheumato.
Okay, so what are the important differential?
Rheumato.
Huh? You see? Cakaplah dengan mic.
SRE.
Yes. Okay, thank you, Hamiza. So yes, so 5 differential diagnoses. So you have to divide infection, inflammation, malignancy, okay, and metabolic cause like your hypercalcemia, all right, and also infiltrative disease, so like sarcoid and everything else. Okay, so Amir and Hamiza, after this you can come and see me to collect your prizes. Thank you.
Thank you, Prof. Sharul, for such an impromptu input into discussion. It's really well received. Any burning last questions? We have about 3 minutes before we close at 9 o'clock. So maybe I'll just ask a quick one. So how is the patient doing now, and what is the drastic change you see from starting the patient on clozapine? What is the best progress that you see?
Okay, so when you become a psychiatrist, one of the things you start to, in general, we appreciate the facial muscles of the face, okay? So when she first came, you can see that, memang macam blunted, tak ada facial expression. So after 2 weeks on clozapine, suddenly she smiled, the lower muscles of the face is working, and she smiled, and the whole team became excited. We were we were jumping, that confused face, we were jumping up and down. I should have the third picture. So yeah, and she was smiling, and it's not a smile sikit, it was like wide smile, and she smiles using her eyes as well. You can smile using your eyes. That's why even you wear mask, I can see you that you're smiling or not, okay? Because you can smile with your eyes. So the whole muscles in the face was doing something and showing that I'm okay, okay. Yeah, so that is but I guess the thing is when the dose was too low. So that's why when she went home, it didn't persist. That smile didn't persist. Yeah.
Thank you so much, Prof. Tuti. I think all of us will agree that today's presentation has been very enlightening. Thank you to the panel of the speakers. And thank you so much, Prof. Sharul, being so participative and helping us in the CPC. So have a good day, everyone. Bye-bye.